Welcome to Pediatric Case Review. In this lecture, we will dive deep into tracheoesophageal fistula, one of the most high-yield topics in pediatric surgery and neonatology. We will cover classification, clinical presentation, pathophysiology, investigations, surgical management, complications, genetic associations, and prognosis through 15 carefully designed case-based questions. Let us get started. Case 1. A newborn is evaluated for a prenatal finding of polyhydramnios. At birth, the infant has excessive oral secretions and fails a nasogastric tube passage at 10 centimeters. Chest X-ray shows the nasogastric tube coiled in the upper chest. The question is, according to the gross classification, which type of tracheoesophageal fistula is most common? Option A, type A, which is pure esophageal atresia with no fistula. Option B, type E, which is the H-type fistula with no atresia. Option C, type C, which is esophageal atresia with a distal tracheoesophageal fistula. Option D, type B, which is esophageal atresia with a proximal tracheoesophageal fistula. Take a moment to think before we reveal the answer. The correct answer is option C, type C, which accounts for 85 to 87% of all cases. In type C, there is a blind upper esophageal pouch, and the distal esophagus connects directly to the trachea, which is why you see gas in the stomach on X-ray. Type A, or pure esophageal atresia, has no fistula and no gastric gas. The H-type, which is type E, presents late with recurrent pneumonia and choking but has no atresia. Always remember, type C when you see coiled tube plus gas below the diaphragm. Case 2. A 3.2 kilogram male neonate is delivered at 38 weeks. The nurse attempts to feed the baby and notices immediate choking and cyanosis with every feeding attempt. Suctioning reveals large amounts of frothy mucus from the mouth. The question is, which combination best represents the classic 3 C's of tracheoesophageal fistula presentation? Option A, constipation, clubbing, and cyanosis. Option B, croup, chest pain, and cyanosis. Option C, crying, coughing, and constipation. Option D, choking, coughing, and cyanosis. Think carefully before moving on. The correct answer is option D, choking, coughing, and cyanosis. These are the 3 classic C's of tracheoesophageal fistula, and they typically appear with the very first feed. Additionally, you will notice excessive frothy oral secretions from birth, which is a hallmark sign. Prenatally, polyhydramnios occurs in about 50% of cases because the fetus cannot swallow and absorb amniotic fluid normally. In type C, the abdomen is distended because air passes via the fistula into the gastrointestinal tract, while in type A it appears scaphoid. Case 3. During embryology teaching, a student is asked about tracheoesophageal fistula development. The fetal foregut normally separates into the trachea anteriorly and the esophagus posteriorly. This separation is orchestrated by the tracheoesophageal septum and various signaling pathways, including SOX2, NKX2.1, sonic hedgehog, and WNT. The question is, failure of which embryological structure leads to tracheoesophageal fistula and esophageal atresia? Option A, the tracheoesophageal septum. Option B, pharyngeal pouches 3 and 4. Option C, branchial arch cartilage. Option D, the aorticopulmonary septum. The correct answer is option A, the tracheoesophageal septum. Around the 4th week of gestation, lateral grooves appear in the primitive foregut, and the tracheoesophageal septum grows caudally to divide the trachea from the esophagus. Failure of this septum to fuse completely results in esophageal atresia with or without a fistula. Key molecular players include SOX2 mutations, which are the most common genetic link, NKX2.1 for tracheal specification, sonic hedgehog for dorsoventral patterning, and WNT signaling for foregut separation. Approximately 50% of cases are associated with the Vactral association. Case 4. On examination of a term newborn with suspected esophageal atresia or tracheoesophageal fistula, the neonatologist attempts to pass a 10 French nasogastric tube. The tube meets resistance at approximately 10 to 12 centimeters from the nares and cannot be advanced further. The abdomen is distended and frothy saliva is pooling in the oral cavity. The question is, on chest X-ray, what finding confirms correct nasogastric tube coiling and also differentiates type C from type A? Option A, nasogastric tube in the left main bronchus. Option B, total opacification of both lungs. Option C, nasogastric tube coiled plus gas in the stomach or intestines. Option D, nasogastric tube coiled plus no gas below the diaphragm. The correct answer is option C, nasogastric tube coiled in the upper pouch plus gas visible below the diaphragm, which confirms type C esophageal atresia with a distal tracheoesophageal fistula. The key clinical rule is straightforward. If the nasogastric tube coils and there is no gastric gas, this is pure esophageal atresia, type A. If the tube coils and gas is present in the stomach, the distal fistula is connecting the airway to the gastrointestinal tract, confirming type C. Type C also carries a higher aspiration risk because both pooled saliva and gastric reflux can enter the airway via the fistula. Case 5. A 2-day-old girl with an esophageal atresia and tracheoesophageal fistula diagnosis is being worked up. The surgeon wants to measure the gap length between the two esophageal ends before planning repair. Chest X-ray shows a coiled nasogastric tube at the level of the second thoracic vertebra. She is stable on intravenous fluids with no oral feeds. The question is, what is the gold standard investigation to measure the gap length in esophageal atresia? Option A, upper gastrointestinal endoscopy. Option B, magnetic resonance imaging of the thorax without sedation. Option C, computed tomography chest with contrast. Option D, fluoroscopic gap study using metal bougies and chest X-ray markers. The correct answer is option D, the fluoroscopic gap study using metal bougies. In this technique, metal bougies are introduced from both the upper and lower ends of the esophagus under fluoroscopy, and the gap is measured in vertebral body lengths. This determines whether primary repair is possible or whether stage procedures will be needed. Alongside the gap study, mandatory investigations include a chest X-ray as the first step, echocardiography to detect congenital heart disease in 30 to 35% of cases and confirm aortic arch side, and renal ultrasound as part of a full VACTERL screen. Genetic panel for SOX2 may be added if syndromic features are present. Case 6. A 1-day-old male with confirmed esophageal atresia and tracheoesophageal fistula undergoes further workup. Spinal X-ray shows a hemivertebra. Renal ultrasound reveals a horseshoe kidney. Cardiac echo shows a small ventricular septal defect. Anal inspection confirms an imperforate anus. This neonate fulfills criteria for VACTERL association. The question is, which component is the most common cardiac defect seen in VACTERL association? Option A, ventricular septal defect. Option B, transposition of the great arteries. Option C, tetralogy of Fallot. Option D, abstain anomaly. The correct answer is option A, the ventricular septal defect, which is the most common cardiac anomaly in VACTERL association. VACTERL stands for vertebral, anorectal, cardiac, tracheoesophageal, renal, and limb anomalies. Cardiac defects occur in 40 to 80% of VACTERL patients and include ventricular septal defect, atrial septal defect, tetralogy of Fallot, and atrioventricular septal defect. Vertebral anomalies appear in 60 to 80%, anorectal malformations in 55 to 90%, and renal anomalies in 50 to 80%. Every neonate with esophageal atresia or tracheoesophageal fistula should be fully screened for all VACTERL components before surgical planning. Case 7. A term newborn with esophageal atresia and tracheoesophageal fistula is awaiting surgical repair scheduled for the following day. The infant is currently lying flat, is nil by mouth on intravenous fluids, has a peripheral intravenous line in place, and is maintaining oxygen saturations of 96% on room air. The question is, which preoperative measure is most important to prevent aspiration pneumonia overnight? Option A, start broad-spectrum antibiotics prophylactically. Option B, nurse upright at 30 to 45 degrees plus continuous repliable tube suction. Option C, begin nasogastric feeds to maintain nutrition. Option D, administer intravenous omeprazole to prevent reflux. The correct answer is option B. Nurse the infant upright at 30 to 45 degrees and use a repliable tube for continuous suction of the upper esophageal pouch. The repliable tube is a double-lumen sump tube that continuously removes pooled secretions, dramatically reducing the aspiration risk. The upright position uses gravity to keep secretions and reflux away from the airway. The infant must remain nil by mouth with intravenous dextrose-containing fluids to maintain normoglycemia. A critical point is to avoid positive pressure ventilation unless absolutely necessary, because it can inflate the stomach via the fistula and cause gastric perforation. Echocardiography must also confirm the aortic arch side before surgery to plan the correct thoracotomy approach. Case 8. A 2-kilogram term newborn with type C esophageal atresia and tracheoesophageal fistula is taken to the operating room for definitive surgical repair. The anatomy shows a short gap esophageal atresia of less than 2 vertebral bodies. The aortic arch is left-sided and cardiac echo shows only a small hemodynamically insignificant atrial septal defect. The question is, what is the standard operative approach for definitive repair of short-gap esophageal atresia and tracheoesophageal fistula? Option A, left thoracotomy with primary anastomosis. Option B, midline laparotomy with gastric pull-up. Option C, right thoracotomy or video-assisted thoracoscopic surgery, fistula division, and primary anastomosis. Option D, cervical esophagostomy with delayed colonic interposition. The correct answer is option C, right thoracotomy or video-assisted thoracoscopic surgery, followed by fistula division and primary esophageal anastomosis. The right-sided approach is used because the azygous vein serves as a landmark and the aortic arch is typically left-sided, keeping it out of the surgical field. Video-assisted thoracoscopic surgery offers advantages including less chest wall deformity, better cosmesis, and equivalent outcomes compared to open thoracotomy. For long-gap esophageal atresia of 2 or more vertebral bodies, a staged repair is needed, either using the Fokker process with external traction sutures, or esophageal replacement using gastric pull-up or colonic interposition. A contrast swallow is performed on day 5 to 7 post-operatively to check anastomotic integrity before starting feeds. Case 9. A neonate on day 7 after tracheoesophageal fistula repair develops increased chest drain output with cloudy fluid, subcutaneous emphysema, fever of 38.8 degrees Celsius, and a rising C-reactive protein level. A contrast esophagram is ordered and shows dye leaking from the anastomosis site. The question is, what is the first-line management for a small contained anastomotic leak after tracheoesophageal fistula repair? Option A, immediate return to the operating room for reanastomosis. Option B, start oral sips to test anastomosis integrity. Option C, remove the chest drain and observe only. Option D, conservative management with nil by mouth, intravenous antibiotics, drain left in place, and total parenteral nutrition. The correct answer is option D, conservative management with nil by mouth, intravenous antibiotics, the drain kept in situ, and total parenteral nutrition. Anastomotic leaks occur in 10 to 20% of cases. Small contained leaks can heal spontaneously with this approach. Large uncontained leaks require surgical re-exploration. The most common long-term complication is anastomotic stricture, affecting 30 to 40% of patients, which presents as progressive dysphagia weeks to months after repair and is treated with balloon esophageal dilatation. Gastroesophageal reflux disease occurs in 40 to 70%, requiring lifelong proton pump inhibitor therapy and Nissen fundoplication in refractory cases. Recurrent tracheoesophageal fistula occurs in 3 to 10% and is diagnosed by bronchoscopy. Case 10. A 6-month-old infant is referred for recurrent pneumonia with 3 episodes in 4 months. Parents report that he coughs and chokes specifically during feeding and gets worse with liquids. He has no trouble swallowing solid foods. He had no issues at birth and his neonatal chest X-ray was normal. He has never had any prior surgeries. The question is, what is the most likely diagnosis and the best first investigation to confirm it? Option A, laryngomalacia, confirmed by flexible laryngoscopy. Option B, H-type tracheoesophageal fistula, confirmed by bronchoscopy and peronesophagram. Option C, gastroesophageal reflux disease, confirmed by upper gastrointestinal series in the supine position. Option D, vascular ring, confirmed by computed tomography angiography. The correct answer is option B, H-type tracheoesophageal fistula, also called type E, diagnosed by bronchoscopy combined with a peronesophagram. The H-type is the great imitator. Unlike other types, the esophagus is intact with no atresia, so these infants do not present at birth. They come to attention weeks or months later with recurrent aspiration pneumonia, particularly affecting the right lower lobe and choking specifically with liquid feeds. The peronesophagram is performed with the patient face down because this position opens the fistula and allows contrast to fill it. Bronchoscopy directly visualizes the fistula opening in the posterior tracheal wall. Treatment is surgical ligation via a cervical approach. Case 11. A premature neonate born at 28 weeks with a birth weight of 900 grams is diagnosed with esophageal atresia and tracheoesophageal fistula. Imaging reveals a gap of 4 vertebral body lengths between the 2 esophageal ends, confirming long-gap esophageal atresia. The infant is on mechanical ventilation and is currently being fed via a gastrostomy tube. The question is, which technique uses external traction on both esophageal ends to gradually lengthen them for a delayed primary anastomosis? Option A, the Fokker process using external traction sutures. Option B, gastric pull-up via a hiatal approach. Option C, colonic interposition via a retrosternal route. Option D, jejunal free flap with microvascular anastomosis. The correct answer is option A, the Fokker process. In this technique, external traction sutures are placed on both the upper and lower esophageal pouches and gradually tightened over 7 to 14 days. This progressive tension stimulates esophageal tissue growth until the gap narrows enough to allow a delayed primary anastomosis using the native esophagus, which is always the preferred option. When the gap is too large even for this approach, esophageal replacement is needed. Colonic interposition uses a segment of colon as a conduit, but carries risks of redundancy and poor motility over time. Gastric pull-up is another option, but risks gastroesophageal reflux disease and dumping syndrome. A short gap is defined as less than 2 vertebral bodies, and a long gap is 2 or more vertebral bodies. Case 12. A 14-month-old former esophageal atresia and tracheoesophageal fistula patient who underwent repair on day 3 of life for type C presents with 2 months of progressive difficulty swallowing solids. She can manage purees but gags on finger foods. Her weight gain has plateaued on the growth chart. There is no fever and no current respiratory symptoms. The question is, what is the most likely complication and the first-line treatment? Option A, recurrent tracheoesophageal fistula requiring surgical ligation. Option B, tracheomalacia managed with continuous positive airway pressure or positive end expiratory pressure therapy. Option C, anastomotic stricture treated with balloon esophageal dilatation. Option D, eosinophilic esophagitis treated with dietary exclusion. The correct answer is option C, anastomotic stricture treated with balloon esophageal dilatation. This is the most common long-term complication after esophageal atresia repair, affecting 30 to 40% of patients. It typically presents as progressive dysphagia for solids weeks to months after surgery, and in infants it manifests as food refusal, gagging, and poor weight gain. Endoscopic balloon dilatation is the first-line treatment and often requires multiple sessions. Mitomycin C can be applied topically for refractory strictures. Other important long-term complications include gastroesophageal reflux disease in 40 to 70%, tracheomalacia in 10 to 20% presenting as dying spells or recurrent wheeze, and feeding difficulties in more than 50% requiring occupational and speech therapy. Case 13. A 3-month-old infant who had tracheoesophageal fistula repair is brought to the emergency room by panicked parents. They describe sudden episodes of stridor, cyanosis, and apparent loss of consciousness during feeding, each lasting 20 to 30 seconds and then self-resolving. On examination, the infant has expiratory stridor and a barky cough. The question is, these episodes are called dying spells or blue spells. Which complication is causing them? Option A, recurrent aspiration pneumonia. Option B, severe gastroesophageal reflux disease with laryngospasm. Option C, anastomotic leak with mediastinitis. Option D, tracheomalacia with dynamic airway collapse. The correct answer is option D, tracheomalacia with dynamic tracheal collapse. In infants with esophageal atresia and tracheoesophageal fistula, the tracheal wall is softened because the distended esophageal pouch compressed it in utero. The weakened posterior tracheal wall collapses on expiration, causing the classic barky or brassy seal-like cough and expiratory stridor. The so-called dying spells are sudden episodes of cyanosis and apnea triggered by feeding or agitation. Diagnosis is confirmed by dynamic bronchoscopy, where more than 50% luminal collapse on expiration is diagnostic. Mild cases resolve by 12 to 18 months. Moderate cases are managed with nighttime continuous positive airway pressure. Severe cases or dying spells require aortopexy, where the aorta is sutured to the sternum to pull the trachea open. Case 14. During morning rounds, the attending presents 2 esophageal atresia and tracheoesophageal fistula neonates to discuss prognosis using the Spitz classification. Baby A weighs 2.8 kilograms, has a mild left-sided pleural effusion, and no cardiac anomaly. Baby B weighs 1.4 kilograms and is premature with severe congenital heart disease in the form of tetralogy of Fallot and requires supplemental oxygen. The question is, according to the Spitz classification, what is baby B's group and its approximate survival rate? Option A, Spitz group 1 with a survival greater than 97%. Option B, Spitz group 2 with a survival of approximately 59%. Option C, Spitz group 3 with a survival of approximately 22%. Option D, Waterston group C with a survival of approximately 6%. The correct answer is option C, Spitz Group 3, with an approximate survival of 22%. Baby B qualifies for Group 3 because he has both a birth weight below 1.5 kilograms and severe congenital heart disease, which are the two most powerful independent risk factors in the Spitz classification. Spitz Group 1 includes infants weighing 1.5 kilograms or more with no major cardiac disease, and carries a survival greater than 97%. Group 2 includes infants with either low birth weight or major cardiac disease, but not both, with a survival of approximately 59%. Overall survival in the modern era exceeds 90% for Group 1 due to advances in neonatal intensive care, video-assisted thoracoscopic surgery techniques, and improved total parenteral nutrition support. Case 15. A genetics consult is requested for a neonate with esophageal atresia and tracheoesophageal fistula type C. The geneticist notes bilateral microtia, choanal atresia, and coloboma of the right eye. The father has similar ear abnormalities. Chromosomal microarray returns normal. The question is, which syndrome or gene mutation is most associated with isolated esophageal atresia and tracheoesophageal fistula outside of the vectoral association? Option A, Char syndrome caused by a mutation in the CHD7 gene. Option B, Down syndrome caused by trisomy 21. Option C, SOX2 enophthalmia syndrome caused by a SOX2 mutation. Option D, Turner syndrome caused by a 45X0 karyotype. The correct answer is option C, SOX2 enophthalmia syndrome caused by a SOX2 mutation on chromosome 3q26. This syndrome presents with anophthalmia or microphthalmia together with esophageal atresia and tracheoesophageal fistula, brain anomalies, and pituitary dysfunction, and it may be mistaken for Char syndrome. Char syndrome, caused by CHD7 mutations, presents with coloboma, heart defects, choanal atresia, retarded growth, genital anomalies, and ear anomalies, with esophageal atresia in 15 to 20%. Vectoral association is the most common context for esophageal atresia overall. Feingold syndrome, caused by MYCM mutations, combines esophageal atresia with limb defects and learning difficulties. Down syndrome is more classically associated with duodenal atresia rather than esophageal atresia. Before our final summary, I want to tell you about our Patreon community called Pediatric Case Review. In this community, all videos are organized by body system, so you can find and access every lecture in one convenient place without searching through your feed. In addition, all the presentation slides used in the videos are available as photos, so you can read through them, review the questions, and practice at your own pace. If you are interested in joining and want to know how to subscribe, simply comment below this post, and we will message you directly with all the details. And that brings us to the end of today's lecture on tracheoesophageal fistula. We covered Gross classification with type C as the most common at 85 to 87%, the three classic C's of clinical presentation, the role of the tracheoesophageal septum in embryology, investigation strategy including echocardiography and fluoroscopic gap study, surgical repair options, postoperative complications including stricture and tracheomalacia, vectoral and genetic associations, and Spitz prognosis groups. If you found this lecture helpful, please follow our channel for more high-quality pediatric case reviews just like this one. And if you have any questions or topics you would like us to cover, drop them in the comments below. See you in the next lecture.